So welcome to this Lyme Disease UK seminar. Big thank you to everybody who's registered today, and a massive thank you and welcome to Dr. Cameron visiting us from the States today, even if it's virtually, to the UK. Thank you for giving us your time so generously. We really appreciate it over here in the UK. Throughout the seminar, everybody's video and audio should be off if possible, and please keep it like that, because then Dr. Cameron won't be distracted and the seminar can run smoothly. The event is being recorded and everybody who's registered will get a recording, so you don't have to worry about trying to write everything down. We do have two co-hosts standing by, Natasha and Anne. And if you have any problems, you can send a message through the chat box and they will pick it up. So do let us know if you're having any problems. Dr. Cameron is going to do a presentation for about 20-25 minutes, and then he will take some questions that have been pre-submitted to us. And if we have time, we'll take some through the chat box. We've had quite a few questions submitted, but we will prioritise the questions about children and adolescents. And if there are any general ones, if we have time, we'll try and fit some in. Just a little intro for Dr. Cameron. So you don't mind if I read this?
No.
Dr. Cameron is an internationally recognised leader for his expertise in the diagnosis and treatment of Lyme disease and other tick-borne diseases. For more than 32 years, he has been treating adolescents and adults suffering from Lyme disease. Dr. Cameron is the past president of the International Lyme and Associated Diseases Society, ILADS, a non-profit medical society dedicated to improving the diagnostic and treatment standards of tick-borne diseases. He is the lead author of ILAD's evidence-based treatment guidelines and is actively involved in raising awareness and in educating the medical community about the complexity of the disease. So that's our intro. Over to you, Dr. Cameron.
Yeah, and thank you for that kind introduction. The last time I had to make a trip all the way to overseas, but with COVID, it's nice to be in my home and for everybody else to be safe. So I wanted to start out this discussion talking about Charles Ray Jones, who is 92 now. He's in my area, and he works just with children and adolescents. And so if we look back at his life, a lot of his was one-on-one details with families, with family members, mothers, fathers, kids, and he could spend so much time getting to know each child. And the reason I mention him is that one of the things I think he did was got the art of observation, getting the whole family involved, because he was involved as a pioneer, but he was facing the same opposition. Mother was not very happy, father was frustrated, the aunt had different opinions. And so over time, I think that one-on-one work where everybody's involved and everybody's doing something was great for the field. That's something I've been doing myself. And I just gave a shout out to Charles Ray Jones. When I first got involved with Lyme disease, I had 3 people in the late 80s. And so I did a lot what Dr. Jones did, is study, listen, get to know them. So instead of just what the CDC had to say, I found that fascinating, the complexities of Lyme disease. There was an article in 1990 where they described chronic neurologic Lyme disease, where they had adults that were sick up to 14 years. And I thought, I'm an internist, I'm an epidemiologist, that they did such a good job in the New England Journal of Medicine describing it. I thought, oh, we finally are going to get a handle on Lyme disease. But unfortunately, the doctors kind of got divided, didn't take on the complexities of Lyme disease. But over time, there's what used to be a lot of symptoms, but I have a much better understanding now with time as to how you got to those symptoms. The way I talk to a patient is that for mechanism is that their immune system sees something from a tick, whether it's a Lyme, anaplasmosis, or babesia, and the immune system gets over involved. So it's kind of like an adrenaline, the fight or flight syndrome. Some people have realized it's the cytokines that are involved. The inflammatory markers are so involved, so active for so long. People are drained. They're exhausted. They can't get the neurotransmitter settled down, so they can't sleep. Every neurotransmitter for mood is up, so they have every mood you can think of. They can say, yes, I have anger, irritability, despair, suicidal feelings, and anxiety. And they come and they go. The neurotransmitters for the sensory system are turned up. So they tend to be sensitive to heat, cold, noise, sound. They're sensitive when they move. So they often have lightheadedness when they get up and down. So at first I had thought it was all a miscellaneous symptoms, but when you look at it from a systems problem, that's why you get all of these problems, but yet nothing structural. And doctors are used to structural problems. So the reason I bring all this up is that most of you listeners already know all these things, but I wanted to make sure that we kind of look at it as not a bunch of miscellaneous symptoms, what's actually going on. And I think that we can engage doctors and families if we break it up into the separate problems. The knee, we already know that's synovitis, that's inflammation of the knee. The whole neuropsych issues where they have neuro and psych issues, rage is probably the most common one. And I had a child who was 9 years old in my office thinking that I was the worst doctor on the planet. I was awful. I was never going to listen to her, never take care of her. But she was just contacting me this week because she's finished her high school in plays. She finished her college degree in biochemistry, and now she's applying for a PA school. And she wanted to shadow me during my work so she could be a PA. So it's that whole anger, rage. I think it's related to neurotransmitters. I want to give a little bit of a history of PANS and PANDAS. Separate totally from Lyme is this National Institute of Mental Health, who thought people were sick from strep. And when they're sick from strep, they would get these movement issues. They get these fits, Tourette's, and plenty of other symptoms. So they called it PANDAS. N stands for neuropsych, and the AS stands for strep. And they thought they were just going to treat the immune response. But since it was associated with strep, they felt they should give an antibiotic. And lo and behold, an antibiotic made a big difference for those symptoms. So they changed the name to PANS. In Europe, they call it CANS, children with neuropsychiatric issues. And so when these PANS and PANDAS went out in the community, there wasn't as much interest in intravenous immune globulin, that is IVIG, because so many people were doing well with an antibiotic. So some of my colleagues in my area and I would talk. And so instead of only amoxicillin, sometimes they would do better if they looked at it as a tick-borne illness. So sometimes doxycycline would work. Sometimes even treatment for babesia would work, because you don't normally get this parasite for babesia treated with amoxicillin or doxycycline. So that's where the etoposide came in. There's a bunch of other diseases that are popping up where big research groups are calling things MUS, where they can't really be sure what the cause is, multiple symptoms, unspecified. There's a lot of interest in chronic fatigue and myeloencephalitis. And so the reason I'm spending some time today dwelling on this issue is that instead of a mishmash of symptoms, I think that we're growing an awareness of what's actually going on. I should mention POTS. That's the leadership in POTS in America is related to cardiologists. They put people on a tilt table, see why their blood pressure is not stable. But people with POTS, if they're kids, they often have a lot more problems with positional tachycardia or positional lightheadedness, positional symptoms. And so oftentimes that's keeping them from participating in sports, let alone participating in school. My first case of POTS was a kid, adolescent in Africa who used to be on stilts, but he couldn't be on stilts anymore. In fact, he had to be lying on the floor. So when he came to America, he came to a POTS clinic. But since Lyme disease was a possibility, he came to me. And so the combination of some POTS work and our work got him back on his feet. He didn't have to crawl around at school anymore. He could sit and then eventually stand and eventually do rugby. So I just wanted to mention that I thought it's rewarding breaking this down and understanding it as actual concrete, well understand symptoms. So when it comes to diagnosis and conditions, is that it's so easy in the UK as well as we are in the States is to get lost in the symptoms, and the doctor looks at a dozen symptoms, picks the psych ones, send them to the neuropsych setting, the psychiatrist, the psychologist, and they're looking at a broader issue. There's another movement now in America to say, well, yes, they're in pain, but they call it centralized pain syndrome. They probably call it different in the UA. They're just saying there's so much pain in these kids. It's unbelievable pain, and the pain medicines isn't working. So they get, as an inpatient, they get admitted and they try to desensitize them from pain or try to do other kinds of behavioral things. But I'm finding more and more of those with centralized pain syndrome. They have been responding to antibiotics. Now they're tough, but I think that one should not overlook a bacterial cause to the centralized pain syndrome. Probably on these diagnostic issues, I need to point out that this COVID virus, it's leading to this long hauler or post-COVID syndrome in adults. Now, usually children are the last ones that get asked, and their parents are the last ones that get asked. So I think it's going to be important to look at whether kids also have long-term complications of this of COVID. And it might turn out, yes, they're not sick enough to be in the hospital, they're not sick enough to be on a respirator, but it could very well give them some chronic problems. The other problem with this COVID is if kids are affected, is that doctors tend to pick a diagnosis and forget that there's more than one cause. So they'll focus in on the chronic fatigue part, the psychiatric part, the PANS, the PANDAS, and so they'll break the kid up into parts or centralized pain. And once you're labeled with something, somebody in the Lyme community is frustrated. Well, is there a theme? Is there a cause? Is there a treatable cause? For some reason, people tend to go for the psychiatric causes so often. Now, it's also possible that you could have two problems. When I was a geriatric doctor, I did these multidisciplinary meetings where people would have Down syndrome, but they were elderly. So the complexities of an elderly Down syndrome had years of having that kind of problem, and they had age. So in this case, I think that doctors who are familiar with Lyme, who have experience with Lyme, are going to run into more and more people who have two illnesses. Could be that they have POTS and Lyme, centralized pain and Lyme. So I think the next complexity for someone with Lyme disease is to take care of not just the ones that are simple that get enrolled in trials, but get used to people with two problems at once. The importance of thinking of two diagnoses at once is reflected even in a rash. They had a study recently that said that if you treated a rash, the first thing they'd pick would be that's a spider bite. Then they would say, oh no, that's cellulitis, which is inflammation of the skin, or that's this or that. And so the last diagnosis they would come up with was Lyme disease. So my preference is that if there's more than one potential answer, is that you try to pick an antibiotic that's going to work for a skin infection, a spider bite, and Lyme. So that means Keflex, which is cephalexin, isn't going to be the right medicine, but sometimes cefuroxime or augmentin, these kind of drugs work for skin infection. Now, it's a little bit more complicated because the skin infections take 7 days of treatment, and you might need to do 3 or 4 weeks for a rash. Now, before we get into the Q&A, I thought I'd mention that since I'm an internist and I see patients all the time, is that with Dr. Jones, I find that just handing an antibiotic out is often not that helpful for adolescents. I like to have them in the room with me. The parents, even if the parents are divorced, I like to have them in the room working through these issues, working through the frustrations for the child. Now, it gets more complicated as the kid gets younger, but I find that the younger the child is that many of them are very aware of what the issues are. And so I think that's important to get that child in there, the parent in there, the grandparents, and try to work through what that child experienced. So if you have a child that has knee pain, that's it. That's simple. But if they have rage, they're lightheaded when they're moving, they can't concentrate, can't focus, they can't sleep. The school expects them to get up thinking and concentrating at 6 a.m, is that instead of just a pill, I find it helpful to walk the child and the family through what to expect. It's very easy to just, find the child in his despair, despondent, and I think that that's as important a part as a pill. There's also people who do alternative medicine. Some of the professionals in our area, they're great at recognizing Lyme. They're recognizing that Lyme is important. But they probably spend their time more with supplements. I like to take the time I have available to do more counseling engagement, and but I'm always encouraging some time spent in that area instead of just blood tests. So I think that if I look at the next step, I'd rather go to question and answer and not take up too much time in just a talk. So I think that my moderators are going to be coming and talking shortly.
Yep, I'm back. Okay, thank you very much for that. So, like I said before, I'll prioritize the questions we've had about children and adolescents. I've also just got a couple in my inbox as well, so I'll go to them afterwards as well. If anybody wants to ask any questions through the chat box, do that, and Natasha and Anne will pick them up and send them over to me. So the first question, have you seen many children or teenagers develop an autoimmune condition after a tick bite or Lyme infection? My son was diagnosed with type 1 diabetes after a tick bite.
It's I don't typically see classic autoimmune diseases from Lyme disease. I've been watching for 34 years in practice, looking. So it must be subtle because I don't typically see it. So I see thyroid, which is an autoimmune disease, typically is often disrupted. I find it's harder to manage sugar, but to actually have full-blown type 1 diabetes could happen. Now, the reason why, from a scientific perspective, why it's complicated is that if somebody is a child or born to a mother who's had Lyme, is that early inflammation or early immune modification may lead to some of these diseases. I tend to take care of 9-year-olds and up to 90 or 100. So by that time, I don't really get a sense of autoimmune diseases, but I'm certainly open to the fact that maybe early on Lyme disease may lead to something. I mention it because it's hard to prove anything in science, right, with some diseases. So there's always the question of, does autism have anything to do with this story? Because kids seem to be born with mothers who have Lyme with, doing relatively well, or at least they don't seem to have as much as I would think. But then they have autism 3 or 4 years later, and you start thinking, is there something going on? And so we need research in that area. We need research on, according to that question, is there a connection between any diseases that we're so used to and Lyme disease?
Okay, so you mentioned Hashimoto's. So somebody's asking, my 7-year-old has constant tummy ache, pains, and feeling sick. Is this how some smaller children present with Lyme? And she's just added she does have Hashimoto's as well at 7. But her main symptoms are sickness and tummy pains.
Well, part of that autonomic nervous system is the adrenaline that takes to get up and down, and it changes position like POTS. That automatic system controls the stomach and the intestines and sometimes the bladder. So it's extremely common to have stomach troubles in children. There's a Dr. Casaro, who's in the next town from where I am, who says that for a parent, sometimes the very first evidence of Lyme disease is often the stomach. Now, it may not be quite enough to show up by a gastroenterologist. It may not be enough to show with any tubes or any x-rays, but it's certainly disruptive to the stomach. So yes, it's extremely common to have stomach problems in kids. There are hardly any articles on stomach problems in kids, but trust me, it's there. Now, back to the Hashimoto's, is that we don't normally do Hashimoto's test in kids. So we don't really know so much when Hashimoto's starts. We don't know as an adult you get Hashimoto's, but it's never know where it starts. So does Lyme push the thyroid around early on, and does it lead to tests for Hashimoto's? Yes, but we got to work out what is the overlap between Hashimoto's and Lyme disease. But yes, be aware of the stomach troubles.
Okay, this one's interesting. Have you seen any cases of bone damage after a tick bite? My youngest son had a large bone tumor at the site of the bite, and all of her eldest son, because she's got two sons who've had Lyme, and all of my eldest son's spinal discs have herniated. So would you normally see those sort of problems?
Well, with disc, I have a lot of patients that are free of Lyme, that never had Lyme that I'm aware of, who have disc disease. So far, I haven't really seen a pattern that Lyme patients have more. That what they do is, when you have pain, and as bad a pain as Lyme disease patients have, they often are getting to orthopedists quicker. And orthopedists are finding these discs quicker. The other thing is that Lyme, through its role in neurotransmitters, turns up the volume of pain. So you might get a disc that somebody doesn't notice, but once they get Lyme, the neurotransmitter is so high, they're in so much pain from that area that it's debilitating. So, but whether it causes, I don't know, but it certainly causes you to notice and causes the discomfort to go up. The first part of the question was, have I seen it lead to tumors of the bone? No, I haven't seen that. But I'm not an orthopedist, so it could be that I don't see those kind of cases.
Yeah. What would you recommend for a teenager whose neurological and pain symptoms, including light and sound sensitivity, POTS, have improved, but who continues to have debilitating fatigue?
Well, another great question. Now, probably the most persistent symptom in Lyme disease is the unrelenting fatigue. So it's very easy to get caught up in chronic fatigue. So let's say, oh, that's it. And there's really not that great a treatment for chronic fatigue. So I'll often find fatigue is still the unrelenting problem for some kids, even if other things improve. Now, during an interview, I'll sometimes say, well, by the way, fatigue is your dominant issue, but what else is going on? So we have to make a decision, is it worth retreating? Or in America, there's so much babesia, which is a parasite. If they have fatigue and they've never been treated for babesia with a tovacone, I'll revisit that area. But yes, fatigue can be pretty persistent. I don't find that many people worry about chronic pain, especially if it's just the knee or ankle. But the first part of the question that you had was pain itself. You know, there's pain all over the place. There's headache pain, eye pain, neck pain. There's back pain, stomach, pelvic, like the pelvic floor. There's the pain of running down your arms. This is like radicular pain. There's even feet. You can hurt on the way to the bathroom. So they call it plantar fasciitis, just that brief time one spends walking. So, and then there's a centralized pain, which means your whole brain perceives pain. And so it's the diversity of pain in someone with Lyme is astounding. And the narcotics don't work that well in adults. And there's a reluctance to do narcotics in kids for good reasons. But I can tell you from adults that narcotics are quite disappointing.
Okay, now this one's really interesting. So, where's she gone? This baby had a tick bite at 11 months. I think the tick, I think Mum says, was behind his ear or somewhere on his head. But Mum didn't know how to remove it. She sought some advice and was more or less told she was time wasting and just remove it herself. She did go to a what we call here, not A&E, the next one down, emergency care.
Okay.
But they basically said the same, just go home and remove it. Anyway, I think from what she said, because it's quite a long question, it took about 48 hours for the family to remove it because they just didn't know how. So he was 11 months old. Around 14 months, the family noticed that the baby wasn't putting his full weight down on his left foot. Mentioned this to the health visitor, who said just monitor him till he's 2 because he'd be walking better at 2. He's now nearly 5 and it slowly progressed to a limp. He's had many investigations, MRIs, dystonia has been thrown up as a possible cause, but every time Mum asks, well, could it be something from the tick bite, she's sort of fobbed off. And although they saved some bloods on this baby when he was sedated for an MRI for further testing, they refused to test for Lyme. She wants to know, in your opinion, should he be tested for Lyme?
Well, I think that even though it was a longer question, it certainly laid out a very common story. of different medical encounters, different questions that are raised. We see that all too often. So the first part of the question is taking a tick off, is that it's better to get the tick off right away, even if the ER does it. Anybody that sees a tick, now sometimes the tick will come off and it leaves a mouth part in the neck. So I'm not sure the mouth part actually has any spirochetes or any infection left in it. The most important thing is at least get the body out and not squeeze the tick. If you squeeze a tick or irritate the tick, bother the tick, or do Vaseline the tick, burn the tick, it can regurgitate blood back into the child. So I always say, well, do whatever you can to at least get it off and don't worry about the mouth part. If you need to, you can always go to the ER to have them try to remove the mouth part. But getting that off. Now, the 48-hour rule is a CDC, which is the Center for Disease Control rule. And that 36-hour rule that it has to be on 24 to 36 is based on a mouse study. Can you find the bacteria in the mouse after the tick's on for a certain number of hours? But the controversy is just because they couldn't grow it in a mouse, is it truly off? There's plenty of people where they got a tick on and in less than 24 hours, they still found that there's an infection. There's also infections beyond Lyme in a tick. So I don't rigidly hold to the 24-hour rule. And also, just because you found a tick and the tick's on there for 48 hours, often it's already been on for a while. And so the clock starts ticking when that tick bites you. Later on, and I don't take care of kids quite that young, so that's why I mentioned Dr. Charles Ray Jones, is that the complexities of with a known tick and a known tick that's on 48 hours is that I like to take each of those observations that she made seriously. And the limping, the neck, the broad range of symptoms, there's so little you can go on in that age. And so yes, the blood test can be done, but the blood test only looks for antibodies, and the antibodies don't always come through as a positive. Also, if somebody's 1 or 2 years old, they'll often have some infection like strep, where it messes up the blood test. And so you think, oh, well, I'll get a blood test, maybe I'll get lucky, but sometimes those antibiotics for normal childhood illnesses messes up the test. Also, those antibiotics mess up normally what you're looking for. You're looking for a rash, looking for a swollen knee or Bell's palsy, and that antibiotic for something else messed up the test, messed up how they present. So we just need a much better understanding of how to take care of a kid and how to have more flexibility in kids that age.
It's very difficult.
I always find that when they're 9, 9 and up is my age, is very easy to communicate with a 9-year-old or 8-year-old with the parents there and observing things. Plus, you can always at that age listen to what happens to the child after you treat.
Yeah, it's really difficult with a toddler. I mean, my background is a pediatric specialist nurse, and there's a real art to working out what's going on with a toddler and that age group. It's really difficult. So you can only really go by their behavior because they can't tell you what's wrong. So a very difficult one. Some other questions, which is, what some parents come up against. So what advice would you give to some parents who are fearful of pursuing a Lyme diagnosis with private practitioners? Because in the UK, the NHS frown on that. And there are children whose parents have pursued the diagnosis through a private practitioner and have been threatened by social services and a Munchausen by proxy label. How do these parents be heard, do you think?
We run into the same problem in the States, is that we always think doctors are fighting with each other, but when a patient comes in, I mean, with their mom and dad, it's easy to get a doctor whose first thing they say is, "Oh, wait, we know it's not Lyme," and you've only opened your mouth, you've only mentioned 2 symptoms, and they're already setting up a problem with communication. So that's frustrating to be a parent, not being able to get the whole story out and get a doctor who's receptive to the issue. And then you throw in that not everybody in the family is on the same page. You'll get family fighting over who's sick. One person thinks it's all psych. The other one says something else. And so Munchausen by proxy meant that somebody came up with, said, well, maybe the parent is obsessed and with the child, and they really think the child's sick. They're not sick. It's got to be a psych problem of the parent. And so with the Munchausen by proxy, it's been used a couple of times with fighting between parents over a custody of a child. Whether it actually goes anywhere, it's hard to tell, but we certainly have more and more kids with social services getting involved. And then if the kid can't go to school, social services is starting to get involved also. They can't get up in time. They can't walk right, especially if they have POTS and they're lightheaded. They can't concentrate and focus. Is that social services gets involved and creates a complicated situation for a parent.
It can be really difficult.
Yes.
What do you think are the major differences between treating Lyme disease in children and adolescents as opposed to adults? Is there a difference?
Well, I find that adolescents and adults are so much easier, and that's my feel. So if I was an internist with an adolescent work, I can find 9-year-olds who are very great communicators with their parents, and I always get them involved because part of their recovery is the child has to be aware of what the illness is. There has to be a buy-in to the treatment. They have to have some patience with the illness. Now, as you get younger, I think that I always tell people that there's a lot of road signs. With an adolescent adult, you might have 10 road signs that say Lyme, and all of them say Lyme. Maybe one might say chronic fatigue, another one say that it's psych. But there's so many signs, if you look at it from head to foot, that help. So when they get younger, you may not get the verbal part of road signs, but there's other road signs. And I think that doctors forget that there can be actually two answers. One of them might be right, but you shouldn't just immediately dismiss Lyme, toss it out without ever considering it. Is that, yes, it's fine to check for thyroid. Yes, it's fine to check for meningitis, but as long as Lyme can do the same thing, is don't toss it out right away if you have an adolescent kid or if you have a 2-year-old.
I don't know if it's the same in the States, but obviously Bell's palsy in children can be the first sign of Lyme in children, and often I've had parents coming to me and saying the first line of treatment was steroids as opposed to antibiotics because the doctor hadn't recognized the Lyme. Can that make the recovery more difficult if steroids go in first?
Yes. There was a study by Dr. Wormser who wrote the IDSA guidelines, the infectious disease guidelines, that if you gave steroids, the recovery from the Bell's palsy was a problem. So, it was published in a paper. It fits with what we know, that if you take steroids, you can suppress the immune system, and the immune system might not be able to handle it so well. part of the issue is that in the medical literature, they call Bell's palsy those who have a virus.
Mm.
And they have seventh nerve palsy for those who have Lyme. So it's the same thing, same nerve, same everything, but they fight over semantics, over words. So so therefore, if they say it's Bell's palsy, you see emergency room doctors will commonly just give an antiviral and a steroid, and not even mention to the parent that, by the way, Lyme disease creates that seventh nerve problem. So I always tell people, well, even if you don't want to give it an antibiotic, you should at least tell the parent that, by the way, Lyme disease does that, because then 3 months later, 6 months later, the parent finally discovers that, oh, that's why the kid's sick. Why didn't they just say that they've thought of Lyme, they purposely decided not to treat for Lyme, treated with the steroid, and precious time passes. I just think they should be more open about it.
Definitely. Okay. Some students with Lyme, the older children obviously, are in a dilemma about whether to take a year out of school and college, or whether to focus on their treatment, or to just push through. Do you have any advice for that situation?
Well, I try to encourage that they stay with school, stick it out school no matter how rough it is. Now, of course, it's easy for me to say, I feel good, but if I can get that child in and the parents in, is that there's some frustrations with, as sick as they are, they get particularly frustrated when they're getting further and further behind from their classmates. They're also frustrated that they're not socialized. Sometimes there's just a little bit of socialization when you fight with school. So if this illness drags out for 2 years, 5 years, is that at least if I keep working with them, try to keep them encouraged, keep them focused, if they can somehow get their education done, then they have something to work with when they graduate. Now, of course, a fair amount of kids, since I see a lot of new people who, they're better pretty quickly. Like I had one yesterday that she's going to college in September. So I said, well, we got 4 months left to get you better. So since she has lots of sweats and air hunger, as well as the other symptoms, I elected to treat for Lyme, but I also elected to treat for Babesia, because with 4 months to go, I set a goal to be able to go to college and be part of the college experience and be well. Now, I can't tell you the ending because it was just yesterday, but I think that if you can, you should try to continue that education. And so that's why there's so many kids that I have who've been able to get done and finish their degree and go off and continue a career. Like I was in Washington, D.C. a few months ago, and some parents came up to me who I didn't recognize. Their daughter, who was on IV and so bad in high school, so disabled. So she was able to do well, finish college, and was in as a nurse in a intensive care unit and had 2 kids. So they just recognized me because I haven't changed as much as they have.
Yeah.
And so it's just nice that a generation later that she's doing well. And that's, of course, all the goals of somebody that works with Lyme, and your organization is try to like get people the attention instead of being dismissed or discouraged. And you already know how important it is to encourage children to try to stay on track if it's possible.
That sort of leads on to another question, is when you've got a teenager who's done fairly well on treatment, but the whole ethos of eating well, resting well, everything that we think should happen, but doesn't always happen with a teenager. How do you get around that? Because they just want to eat what their mates eat.
Well, I find that some of the approaches is to take like an elimination diet, eliminate gluten, dairy, and a variety of other issues that is that there's so much time spent on that. Is sometimes it's hard to engage the kids on in an education and what antibiotic to use. Almost everybody can agree to stay away from simple sugars, processed sugars, stay away from alcohol, which is pretty easy when you're 15. But still, I think that's, even though, yes, there's some great things to be said about those kind of diets and try to avoid leaky gut, is that you have to pick your battle and pick how much you can accomplish as a family. And so if they're embittered by the diet that they have, or having troubles with it, I have to always do what I can, negotiate what I can, and that seems to serve me well, rather than a rigid adherence to a dietary recommendation is the top issue, and then I create a war otherwise.
Yeah, I mean, that's exactly something. Somebody came to me very recently about a child who may have to go back on treatment, but was very reticent to do that. And we talked about it's not just about this is what you've got to do, it's about giving some control back to that child and dealing with the psychology of what that child's going through. Would you agree to that? That the child has to have.
Yeah, that's why I tend to spend more time on the conversation, the engagement, the buy-in, because it's helped so much to pick my battles. And so you stated it really well. Is that that I think is much better than being too dogmatic and then losing the child. But you win your recommendations, you feel good about your recommendations, but you don't really have a plan that's going to work. Also, when the kids look back on it, they often look back and reflect on what they think was worthwhile and not worthwhile. And so sometimes you're absolutely convinced gluten-free diet is the absolute diet, and they go back and say don't have the same conclusion you have. You're setting up some resentment potential. So I try to at least get the kid involved in where's the best plan that is the best compromise for what they're experiencing.
Yeah, which is being a normal adolescent, whether you're ill or not, isn't it?
Oh yeah, I tell people that, like I had one today in my office. So I said, she said, she has the movement issues, the pseudo seizures, the weight issues. But I told her that, well, you're 14, you're a teenager, so you have to have those issues also. So and then I think she had her period this week. So I said, between all those issues, that normal, you just have to be aware that everything you're having doesn't have to be only disease. Some of it's just healthy teenage issues.
Absolutely, I absolutely agree with you there. Because you can't fight everything with a teenager. It's got to be a balance. How much do you think that congenital Lyme is a problem?
It's Dr. Charles Ray Jones says it is, but you can only do so many things and a practice. So it's always hard to study the field. I find that the same thing that Dr. McDonald found years ago, which is that it seems like babies are born looking good and the organs are fine, the ones I've seen at least. And he came with a study that looked like they did pretty well. It's just that these things you can't see so much, like the autism issues, learning issues, ADHD issues, are they connected? I don't know. Now, some doctors treat antibiotics during an entire pregnancy, but that's because not all doctors are on the same page. That doesn't mean that I'm right and they're wrong. It's just there's some doctors feel that just in case it's gestational issues, why not say antibiotics the whole time? I tend to treat during a pregnancy if they have symptoms, and try to not do more than I need to. I think that the whole question of breastfeeding, like should you breastfeed or not breastfeed? Because they may prove down the road that breastfeeding is not an issue. And then you got a mother, you said, don't even think of breastfeeding. Don't. And then later on, they might prove that was never an issue for most people. Then they wish they had breastfed. So I try not to be totally dogmatic on like never get pregnant, never breastfeed, is that we just don't know enough to answer the question. So I dragged my mom and dad in, the prospective mom and dad, and discuss an issue where we're all involved as a team. I don't want just the mother involved making these tough decisions. And I find that in the absence of facts, it's always easier to come up with some kind of a consensus.
Yeah, that was actually one of my questions about whether to treat or not during a pregnancy. So you've answered it before. We've had a question through the chat box as we're going through time. It's really long, so I'll try to get it down a bit. But a mother was bitten 28 years ago and diagnosed with Lyme, Bartonella, Babesia, Mycoplasma pneumoniae 4 years. Hang on. 4 years. Oh, she was diagnosed with all those 4 years ago. Her 13-year-old daughter was born with an opiates withdrawal sounding scream, severe reflux, horrific rage. Babies have horrific rage, and meltdowns as she's been growing up. Early puberty, height growth at 7 years old, debilitating knees and ankle pain, as well as severe dyslexia, sleep issues, nightmares and sleepwalking. Trouble with friendships. After the mother's own diagnosis, the daughter also tested positive. Her son has severe OCD, anxiety and depression, and sadly nearly took his own life a little while ago. He isn't ready to look at testing, as can't bear to face that Lyme has been responsible for his problems too. Could this mother have passed on Lyme to both her children? I mean, it's a really difficult to answer.
I was able to look at it on the chat box on the right also, but so it's see that's where gestational diabetes comes up. Gestational pregnancy comes up as an issue. Is that we have mothers where the story starts pretty early, and so because we don't have a great enough test to know, we can't be sure it's connected. I always think it's always possible just a mother being sick alone is stressful during the entire pregnancy. If there's that sick, it may be that's it. But the day they're born, there's also exposure. And so I'm trying to at least mention that it's tough to work in an area with no science, where we have predictable tests or predictable readings. Once they're at this age, then I try not to spend all my time on is it gestational or not gestational. I spend my time on what do I do with what I have right now. Mm. Like if Lyme disease is one of the possibilities, I'll try to spend a lot of time on making sure it's nothing else. I'll get a neurologist involved, a rheumatologist for each issue. A lot of people have visual problems. They're strange vision, visual blurring, and visual distortion. So I'll get an ophthalmologist involved, a gastroenterologist for that. But as long as Lyme disease is a possibility, I'll look a second time at that. And so that's why, she's asking questions about what to do. The question is not to put everything on Lyme, but to just keep Lyme on the list. And when it comes to the son having frustrations with it, is that's part of the buy-in when they have OCD, anxiety, depression, is that you'd be surprised how many people who actually have Lyme who haven't bought into being sick. The only reason they come see me is because someone makes them come. Someone says that you have to come in. And so I always refer to them as a hostile patient. They're pleasant. A hostile witness in America means they're in because of a subpoena. But a hostile patient means they're there because mom made them come or their spouse made them come, and they're there, they're polite, but they've been putting it off for a long time until someone makes them come sees me. And so that's why having this 20-year-old trying to figure out how to get them on track and looking at those symptoms instead of assuming it's only a psych. Even the 20-year-old may be convinced it's only psych. And so it's hard for that mother to have a plan for that 20-year-old. And it could be two issues too, that with the daughter is that having opioid withdrawal sounding scream is that's a pretty strange diagnosis to be using the word opioid withdrawal, unless it's just hard to tell. I'm not sure how they got to that answer. It's just use a common sense that doctors have as to try to work through diagnostic issues.
Well, I guess as we're coming up to a few minutes to 8 here, 3 there, I think. What advice would you give to parents and older children as well? Because obviously they talk to you as adults. If they just feel there's no hope of getting better, which many patients go through that.
Well, there's this despondency or despair that button, the neurotransmitters that are turned up to high. I think it not only turns up the anxiety button, the sadness, the irritability, the rage, but it turns up the despondency, the despair. So I often tell people that we don't need the Grim Reaper, we just bring your son in. And so just to highlight how deep the despondency could be sometimes. I find that that Dr. Bransfield, the psychiatrist in the U.S., is correct. He says an awful lot of kids are suicidal. He even says some of them are homicidal. But the very fact that he talks a lot about suicidal, it means how far the kid can go in the despondency. Now, he didn't say that necessarily suicide, but suicidal is fairly common. And if I do a checklist where I include suicidal ideation, you'd be surprised how many people have that as part of their story when they're doing an inventory of how they feel. So yes, I think that despondency is extremely common. And once again, the counseling, engagement, awareness that I'm comfortable with that conversation, and that the parents are aware that kind of feeling takes place, that they should include that in their discussion and include that in one of our goals to get rid of that despondency.
Okay, well, there's a few others, but we would run over time. So maybe if I just make a note of them when we finish, maybe if there's any outstanding ones, I could maybe just ping them over to you and
Okay.
see if you could answer them. So thank you for that. That was really, really interesting. I mean, I haven't got any children with Lyme, but my background is in pediatrics, so very interesting for me to listen to that.
You're a great interviewer in terms of pulling those questions up and working with you. So I appreciate the time.
Oh, thank you. Well, I just wanted to say from everybody at the charity and everybody who's registered today, massive thank you to you, and it's lovely to meet you. For everybody who's registered, many people know that we're doing these seminars regularly, and the next one that will be advertised will actually be about PANS Panda with Dr. Tim Uby. So that will be going out for registration soon. So look out for that advert. So again, thank you very much. And thank you to everybody who's attended this evening. Thanks.